Okay, our first question for Chapter 6. Procedures do not always carry the same weight. How does the coder determine a principal procedure? What about a significant procedure? Okay, a principal procedure is one that is performed for definitive treatment rather than diagnostic or exploratory purposes. It can also be a procedure that is necessary to take care of a complication. Sometimes two procedures can meet the definition of principal procedure. Now, if that happens, the procedure most closely related to the principal diagnosis should be coded as the principal procedure. Now, a significant procedure must meet one of the four following criteria. 1. It is surgical in nature. 2. It carries a procedural risk. 3. It carries an anesthetic risk. 4. It requires specialized training. Now, in addition to procedures completed in the operating room, emergency room procedures can qualify as significant procedures, provided the above criteria are met. A coder should check any emergency room records to be certain no significant procedures are missed. Okay, next question. What are some reasons for coding all procedures, even those that do not affect payment or reimbursement? What are some reasons for not coding all procedures? Some facilities use codes to do reporting and statistics for the hospital. Hospital administration, physicians, and other hospital personnel may want reports that show how many transfusions were performed in a certain time period. Or perhaps a radiologist wants to know how many MRIs he or she performed in a given time period. In these instances, the only place where these are captured might be in the codes. However, although the coders review the entire record, it's time-consuming to report all of these procedures, making it sometimes difficult to meet productivity and hospital financial goals. Not coding all procedures has its benefits. The coders can spend more time concentrating on coding the significant procedures that impact reimbursement. Their productivity is then increased, helping the financial goals of the hospital. The data that might need to be collected by physicians or hospital personnel relating to less significant procedures can most likely be collected through the charges in the charge master found on each hospital account. Okay, our last question. Why is it important to have an operative report and a pathology report in those cases in which a specimen is collected? And our answer, both are equally important because they both can impact the MSDRG assignment and therefore affect the reimbursement. For example, the operative report contains valuable information describing whether the patient had a biopsy, excision, or removal of entire organ. All three of these different procedures done on any organ can significantly change the MSDRG. In addition, the pathology report provides the microscopic description of the disease, growth, etc. In many instances, the MSDRG can change depending on whether the principal diagnosis is a benign or a malignant tumor, or an acute versus a chronic condition, when can many times be determined only by a pathology report. Okay, here are some coding tips for the information discussed in Chapter 6. Procedures that might be considered significant procedures are vascular catheter placement, administration of chemotherapy, transfusions, and suture laceration. Why are these significant? Are they surgical in nature? Do they carry a procedural risk or an anesthetic risk, or require specialized training, or all of the above? It's okay to code a procedure even though the procedure might not have been completed the way it was intended. The procedure still may have an impact on reimbursement, so therefore it should be captured to the furthest extent the procedure was performed. This could be lost revenue for the hospital if the coder misses coding the unfinished procedure, assuming it should not be coded since it was not completed. It's important to have a facility policy and should always include a copy of the most updated UHDDS reporting standards for diagnosis and procedures and AHIMA standards of ethical coding. These should be the basis for facility policy along with any hospital-specific guidelines necessary for the institution to capture the data it needs for its personnel. For example, teaching hospitals may ask for more diagnoses and procedures to be coded since the medical students and resident may need extra information for profiling and credentialing. Hospitals that perform clinical studies or trials may also need more codes than usual to be collected in order to support data collection for research purposes.